EHR and the Practice Partner Research Network webcast. Today's event is being recorded. Later, there will be an opportunity to ask questions. At this time, I would like to turn things over to Andrea Wessel. Ms. Wessel, please go ahead.
Great. Thank you very much, and good afternoon, everyone. I am joining the call from Charleston, South Carolina, and add my greetings from the research team here at the Medical University of South Carolina. Our agenda for the next 45 minutes or so together is to give you an overview of PPRNet, answering some of the questions around who we are and what we do, describing the value of belonging to the network from the perspective of our members, and finally ending with how to join and get started with participating in PPRNet from your perspective. As Yolanda mentioned, I'll be happy to take questions at the end. Logistically, it's probably easiest for me to field the questions through the question and answer button at the top of the live meeting. And then we'll also have a chance for you to unmute your phones, and we can have more of a one-on-one dialogue to make sure that we've addressed any questions or concerns that you may have. The mission statement of PPRNet is that we are a practice-based learning and research organization designed to improve healthcare, both in our member practices and elsewhere across the country. In terms of our history, we were founded in May of 1995 as a collaboration between Practice Partner and the Medical University of South Carolina. And our current activities in terms of the reporting functions that I'll be describing in more detail in just a couple of minutes were formalized in 2006 in a contract now between McKesson and MUSC. While we do have this collaboration and partnership with McKesson Practice Partner, the majority of our funding, in fact, close to 90% of our support is from federal research grants. And I'll be sharing with some opportunities with you for how to become involved in those as we move through the presentation. If you've never heard of a practice-based research network, please allow me to tell you just a bit about what that is or what these are. PPRNs are often located and central geographically, so many states have PPRNs that function across maybe their family medicine physicians or internal medicine physician groups. And in general, they consist of practices that are devoted principally to the primary care of patients. And in terms of their research purpose, they focus on answering community-based healthcare questions and engaging in quality improvement activities, different from individual clinical trials or testing either new diagnostic approaches or testing new drugs. The other key feature of a PBRN is that they maintain an ongoing commitment to network activities, both in terms of projects as well as relationships with their members that transcend individual projects. Our membership is currently at 183 primary care practices across the country, and you can see our membership map there on the right-hand side of the screen. The majority of our members are small to medium-sized primary care practices, so 5 providers and fewer make up the majority of our practices. And again, these are split between practices that identify themselves as family medicine practices, internal medicine practices, a handful of medicine/pediatric practices, and those are the bulk of our membership. We have 3 very specific aims in terms of what we are here to do. In the following slides, I'll walk through each of these aims to give you more information on how it is we accomplish our goals. The first is that we turn clinical data, and that's data from the McKesson's suite of EHR products, turning clinical data into actionable information in the form of practice performance reports. Our second aim is related to our research mission, and that's to test interventions in practices using EHRs that serve to improve healthcare quality. And then finally, to disseminate successful interventions, both to our membership, but also to other primary care practices across the country and even beyond. We see this, and our practices see this, as a win-win-win relationship, really for all parties involved. For McKesson, this partnership, both with the PPRNet research team and with PPRNet practices, provides a niche for them in the field of EHR vendors, as well as providing an academic partner in the form of our relationship with their relationship with our research network. We have a base of loyal clients, again, some that have been using the record for years that are a part of PPRNet, and showing this evidence and being able to help prove things or provide evidence related to the effectiveness of EHR implementation and improving health care across a variety of domains. For those of us at MUSC, we have the great win, if you will, of working with practices in the quote-unquote real world. So working with folks who are using the EHR, clinicians and staff who are interested in participating in quality improvement interventions, and that's one of the big wins, one of the many wins for us, as well as a clinical database with information from practices' EHRs that we're able to use over time. I'll focus a bit more on our practices' benefits and the things that they identify as their wins, and just a few are highlighted here on this slide. Practice performance reports and recognition for achievements on these reports. Quality improvement assistance related to research network, or related to research projects. And then being a part of something bigger, so participating in a learning network of other mainly private primary care practices across the country that use the same EHR and may be dealing with many of the same struggles of day-to-day practice, survival, and being able to kind of go through that together. There's funding available for our meetings depending on the project, and we offer CME for all of our activities. So again, let's dig a bit deeper into our activities and specifically the benefits that our members receive. And we're going to organize this next discussion along our aims. Our first aim, remember, was to turn clinical data into actionable information. And many of you may have first heard about PPRNet related to the performance reports that we provide our practices. These reports are designed to assist you in quality improvement and patient outreach. Again, they're for your use. We don't dictate what you do with them. And they're based on data from your periodic extracts of your McKesson EHR. They illustrate practice performance on the practice level, so this shows performance over time, as well as the patient level, which functions much like a registry, as well as provider level for practices that have larger groups of providers. Our reports give you feedback, provide feedback to you on over 50 quality of care indicators. And you can see the categories that these represent on the left-hand side of the slide. Many of these categories you wouldn't be surprised, and these are the things that you would want in a quality report. For disease processes like diabetes and cardiovascular disease, but then also a large number of preventive health care measures such as immunizations and cancer screening. We include process measures in our report, so this is showing, has a test been done or has a specific medication been prescribed, as well, and then also outcome measures when available. So achieving specific clinical targets, for example, hemoglobin A1C in patients with diabetes or blood pressure targets for patients with hypertension. Our data collection process starts with the practice and what you're doing in terms of daily care with your patient. So that's the point in the circle that will begin in terms of where we get our information from. So again, you're providing care. This doctor's example, I think maybe is getting ready to give a flu shot, although I can't really tell. So that data is then entered into your electronic health record. And once a quarter, practices run an extract program, and that extract program is then uploaded to a secure site. McKesson practice partner staff in Seattle help make sure that the extract is complete in terms of the data completeness or the certain size of the extract that we would expect. And then those data are sent to us in Charleston. The PPRNet office is here. We process this information to provide details back to you in the form of your practice reports, and then also use the same data when it comes to evaluating projects related to our research missions. And then ultimately, we see this cycle as a continuous circle where your practice report then helps you evaluate the care that you're providing, and then will impact the future care that you provide, which will then be reflected in your record in the future quarters as that cycle repeats itself. I'm going to show an example of our performance reports so that you can see exactly what these look like. I'll walk first through one process and one outcome measure, and then we'll look at the patient level report as well. The practice report is illustrated by the graphs on the left-hand side of the slide, and then our patient level report is the Excel spreadsheet shown on the right-hand side. Before we look at these reports together, it's important for you to know what type of information is even available to us in terms of the types of clinical data that we receive from your extracts. We receive enough demographic information about your patient to understand their eligibility for quality indicators, but not enough to ever be able to identify them. So we do receive birth dates and genders. And then the other information that we get in the extract are from structured fields within the record. And so these are things like diagnoses and problems from that section of the chart. We pull medications just from the medication list, laboratory tests, vital signs from that section of the chart, and health maintenance items. We also pull all of the note titles within the system, so we're able to use that when it comes to looking at eligibility for certain problems or certain things from the diagnosis list. The data that we don't receive is also important so that you know where we cannot see information in terms of calculating your practice performance. And those are patient identifiers, as I've already mentioned. Also, due to confidentiality, we don't receive the text of your progress notes. So, you know, if medications are only noted in the text of notes and not on your medication list, as an example, we will not receive that information. And at this point, we don't receive clinical elements as a part of the data extract, but we receive many things in the data extract, and that's what we use to process your reports. This graph, again, is an example of one of our process measures. You can see the title of each graph includes the indicator description, and for this one, it's patients with hypertension. This is from an actual practice report from the fourth quarter of 2010. So patients with hypertension with a blood pressure measurement in the last 6 months. The things that I'll lay out for you in terms of introducing you to this type of graph is first that this is a statistical process control chart. And you'll see the elements of detecting change much better in the next graph. But what this helps you see is when there's variation or when there's actual changes over time in your practice. On the right-hand side of the graph, you can see that there are the first line in blue is 3 sigma limits, and this is just meaning the top of the kind of the change field, if you will, for the statistical process control chart. And then the first line that you see in black is the benchmark. Our benchmarks are achievable benchmarks of care, so these are not arbitrarily selected numbers, but these benchmarks are calculated in January of every year, and they reflect essentially the top 10% of PPRNet practices. The benchmark accounts for practices with very small sample size and takes that into account, but this is the way that you're able to compare yourselves to your peers. So our benchmark, again, the top 10%, and then you can see a little bit further down on the graph the PPRNet median, and this is the 50th percentile, so half of our PPRNet practices fall above this line, and then half of our practices will fall below it. When national numbers are available for our indicators, those are also shown on this slide. And so you can see this practice's performance with the red dots shown month by month. On average, they have measured blood pressure in 76% of their patients with hypertension within the last 6 months. In order for a patient to be included on this graph, they have to be considered active, quote-unquote active. And that means that they've had a progress note in this patient's chart, or in this practice's chart, excuse me, and they've not been marked as inactive or deceased in terms of patient registration information, so that we see them as active or eligible for a blood pressure measurement. In addition to seeing where this practice stands, you can see that over time, over the last 2 years of this report, that there's been very little fluctuation in terms of the percentage of patients who have had their blood pressure checked. So this, again, is our process measure related to hypertension. An outcome measure for hypertension is shown on this next graph, and this shows the percentage of control. So how many people have had a controlled blood pressure in this practice? Again, these are actual practice graphs. And the differences that you can see here is that the system has flagged a significant change. And over the last 6 to 8 months, this has been an improvement. And so this shows the practice that they have achieved an improved performance in terms of the percentage of patients meeting this outcome goal. And they're now around 63%. So about 62 to 63% of their patients have met this blood pressure target. And you can see in terms of comparing their performance to others, this is below the PPRNet median and below the PPRNet benchmark, but for now is above the national average, which, as you can see here, is much lower at about 30%. So practices, again, use these types of the report to evaluate their performance over time. Excuse me. And then they can use the next piece of our reports in terms of patient-level reports to identify patients maybe who haven't had a blood pressure checked in response to the first graph, or those who have had high blood pressures at their most recent reading. So let's look more in depth at our patient-level report features. A working knowledge of Excel is definitely a plus when it comes to manipulating the patient-level reports, but it's not essential. Each active patient in your practice is represented on one row of the Excel spreadsheet within this report. And what you can see in the colored boxes here are called macros within Excel. And these are just standard sorting tools that we've developed, and you can just click on the box and the spreadsheet is then filtered for you automatically based on the criteria. So you can see here we could use one of the macros to show patients with hypertension who have an elevated blood pressure that match that last graph, or in the example that's highlighted here, showing patients who may be in need of a flu vaccine. It's important to point out here, you'll see in this very first column on the slide that PPRNet ID is listed. And because of the confidentiality issues that I mentioned before, this identifier is not the same as your medical record number. It's an internal number that allows us to track this patient's information over time, and you are able to, there's a system within Practice Partner that allows you to identify individual patients. But again, for confidentiality reasons, we include this PPRNet ID on your patient level report. And this is a screenshot of the system that exists within Practice Partner that you can use to take the identifier from our patient level report to transition to your medical record number. It's available on our website in terms of downloading, and most practices actually already have it within their PPART directory. For those prospective members on the call, this may seem like way too much information, but the bottom line is that there is a system in place that allows you to identify your patients. In the same Excel file where your patient level report or your registry lives, there's also another tab within the file that gives you your provider report. So you can see here, this shows provider level performance as well as your overall practice performance on each of our indicators. And so it occupies several different columns that we'd be able to see if we just kept scrolling to the right here. Moving on to our second aim, and again, I wanted to spend the bulk of our time talking about the practice performance reports because that may be one of the first value-added services that you choose to take part of related to PPRNet. But our second aim is related to our research mission, and we've been very fortunate over the years due to the involvement of PPRNet members in our projects. The majority of our research is funded from the federal government, largely from the Agency for Healthcare Research and Quality, but also from the National Institutes of Health. And in these research projects, our members receive on-site visits to help with quality improvement and also to talk about the kind of nuts and bolts or the learning behind specific projects. Practices also receive specialized reports related to the research project as well as meetings. Again, this research has contributed a great deal to the lessons known about what works in practices that use electronic health records. And we've been able to show progress in overcoming quality problems related to the delivery of preventive services in primary care, as well as chronic disease management, and most recently, medication safety. To give you a sense of what types of projects we tend to work on, we wanted to share with you just some of our ongoing research projects. A lot of what we do is in the TRIP world, and that's stands for Translating Research into Practice. We have an ongoing project looking at the implementation of alcohol screening recommendations, and particularly the impact of alcohol screening and blood pressure and diabetes control. We're also evaluating a progress note template that's designed to reduce the inappropriate prescribing of antibiotics for viral respiratory infections. Then we have an infrastructure grant also looking at building the information and the types of information we have on complex patients in our practices. And we're currently still recruiting. We've just started a medication safety project that's a follow-up or kind of the next generation of improving medication safety in PPRNet, a follow-up to a project that was just completed in September of last year. And I'd be happy to share additional information related to that project if anyone has questions. So our third aim is related to dissemination, and that's, how do we spread what we've learned to more people? And we do this in a couple of different ways. We have annual network meetings, typically here in Charleston, and this provides an opportunity for our members to come together to share best practice approaches and lessons learned with one another. It's also the chance that we have to share best practice awards and recognize our practices for high performance on the PPRNet indicator set. And for practices that participate in our projects, we are able to support some travel for the meetings. This picture here is from our meeting last year, and it just so happens that everyone on the panel is a female, but these are providers and nursing staff from our alcohol screening and management project, and they are sharing success stories on how they've involved their staff in a refined approach to screening for alcohol use in their practices. We believe that our members say it best in terms of why they belong to PPRNet and what keeps them engaged and keeps them involved. So we wanted to share with you what they say they see as achievements. We have a number of practices in the network who have achieved National Committee for Quality Assurance, so NCQA recognition for both the patient-centered medical home system as well as diabetes and the physician recognition programs. Our practices have received state awards for excellence, and they also use our PPRNet reports for fundraising initiatives for practices that are involved in that type of work. And then also payment for performance initiatives or payment for quality initiatives from local insurers and independent physician associations in our practices across the country. Our practices tell us that they've provided feedback that they appreciate that we are committed to helping them improve their practice, and that's our overall goal, both in terms of our practice report responsibilities as well as our research. And in terms of participating in implementation projects, practices have seen positive impacts on the quality and safety of care that they provide. And they're motivated by performance and motivated by the performance and changes that they're able to see on their reports. We wanted to share just a couple of quotes with you from our member practices. And this first one is from a relatively new member in Kansas. And Dr. Kraft says that Salina Family Health Care Center has been a PPRNet member for just under a year. And as a federally qualified community health center, we have reporting requirements to our funding agencies. While these reports are doable in Practice Partner, they're time-consuming, and the PPRNet reports have saved their clinic about a week's worth of staff time in these reporting features. Dr. Kraft says that he looks forward to using reports to an even greater degree in the future and see this as an integral part of the patient-centered medical home model. So we definitely appreciate Dr. Kraft's involvement, and his practice has joined our medication safety project, and they'll be participating in that as one of their first research projects with us. So we're excited to have them involved. Dr. Sue Andrews has been a member of PPRNet for many years, and she says that being involved in PPRNet has re-energized our practice. Having real data to look at tells us where we are doing well and what we need to work on, and she believes that the PPRNet improvement model really works. This is Dr. Andrews from Tennessee. So how do you join and get started? For the prospective members on the call, the requirements are just to have a McKesson EHR. While Practice Partner is in the name of the network, we do have member practices that use the LITech software as well as Metasoft products. And so that's the first element. For those of you that are already using a McKesson EHR, our registration is all available online, and our membership coordinator, Leslie Abbott, would be happy to help walk you through that or answer any questions, and we've included her email here for your reference. I also have included my email and telephone number just up on the attendee list in the information about me, so feel free to access that. And I think we're going to have plenty of time to answer questions or take comments at the end, and I'd be happy to take those questions as we progress. Our extract process occurs quarterly, as I mentioned, and so our next extract requirements will be coming due the first week of April, and it only takes a few minutes for these extracts to run. We do ask practices to submit an initial data extract prior to this period, so if you join today, we'd like to get your initial data extract before April, and then each quarter thereafter you can run your data extract while you're running your patient record system. You don't have to have that closed out. The extract program lives in your PPART directory, again, making it easy for you to run this extract on your end. And again, both McKesson Practice Partner personnel as well as PPRNet staff members can help walk you through this process, particularly the first time you do it, in terms of letting you know which of these buttons to select and which specific dates to include. We do have a web page. This is just showing you some updated pictures of our PPRNet web page, and this is where we post reports. Each practice has a password-protected folder. We are not in the business of sending you any extra paper. That would be a huge conflict to those of you using EHRs, and from our perspective as well. So your practice's reports are posted here quarterly. Again, we have entered the 21st century for sure and have more information about what we do and how we do it, both on our website as well as via our Facebook and Twitter accounts. So we would look forward to engaging in more conversation with you in any of those arenas and also we'll be able to do that. Now, I went a bit quicker than I usually do just because I was afraid my voice wasn't going to hold up, but I'm happy to take questions via the question and answer button at the top of the live meeting. And then if we run out of questions that way, if people would rather unmute their phones, we can process them that way as well.
And to ask a question over the phone lines, please press *1 on your telephone keypad. A voice prompt on your line will indicate when your line is open. Again, that is *1 if you wish to ask your question over the phone at this time. And no one has signaled at this time, but again, that is *1 if you do have a question over the phone. And we'll take our first caller. Please go ahead. Your line is open. Please go ahead with your question. And hearing no response, we'll move to our next question. Caller, please go ahead.
Hello, this is Dr. Houchin. Can you hear me?
Yes, I can hear you. Hi, Dr. Houchin. Where are you calling from?
St. Peters, Missouri.
Great.
We have several projects going on with the meaningful use and a variety of other things, and my staff is stretched kind of thin. I'm interested in this, but how much actual time is it going to take from my office manager to get this going?
In terms of getting going and joining the network, the pieces of information that we need from you to get started are very minimal. So, our registration form asks very basic questions that your office manager could likely answer in 5 to 10 minutes in terms of, your provider codes, who's in your practice, where are you located, those sorts of things. Mm-hmm. The initial extract, in terms of running that, it depends on how long you've been on the system. How long have you used either Practice Partner or one of the other products?
I think we're close to 6 years.
Mm-hmm. So sometimes the extract program the initial can take 30 minutes. Sometimes it takes a little longer than that. But the McKesson staff can help walk you through that at the very beginning. Excuse me. And so in terms of staff time and getting your first report, that's really all it takes, signing up with us and getting your first extract done. The other kind of level of involvement would be more if you chose to participate in one of our projects. And that would depend on the project, really. But we're very clear up front in terms of, what you're agreeing to and then what we are agreeing to in terms of, the benefits that we give practices. But in terms of getting started, I think you'll find that the time commitment up front is minimal. What may take more time is when you get your first report, particularly if you see things that you want to work on, right? Or if you see things that maybe the performance doesn't match where you thought it would be. And that type of practice evaluation is difficult to predict in terms of how much time it would take. But the upfront piece of just getting started is minimal.
Okay.
Does that help answer your question?
Well, yeah. I think it may not, even though it's a minimal amount of time, we have to do 2 Practice Partners upgrades over the next 30 days so that we can be
to get ready for
meaningful use. So even another half hour of their time might not be feasible right now. But thank you.
Okay, you're welcome. Thanks for attending.
Mm-hmm.
And again, that is *1 for any questions at this time. We'll move to our next caller.
Hello.
Hi.
Hi. My name is Patty Harrison. I'm with St. John Health System in Tulsa. And years ago, we tried to work with PPRNet on extraction of our data. Currently, our database without any images included is over 850 gig, and I'm wondering now if you would anticipate we would have the same issues with extraction, if things have improved so that larger databases are easier to extract, and if there's any other customers with databases as large as ours that are
big.
Yeah.
How many providers are you talking about, Patty?
We have about 100, probably between 150 and 175 active providers using the system, actually documenting within the system. We have more that use it for reference, like the hospitalists or the ER doctors. But
in terms of the practices that contribute to the primary care practices, is about 100.
Mm-hmm. Well, it's not just primary care. We have some specialists, too.
Okay. The extract program itself has, there have been minor tweaks to it over the years, for sure. But it may be better for us to talk offline about how your practice would want to use these reports in terms of making sure that the value, that it's valuable for you. Particularly, we do have large systems that receive reports. What makes it difficult, particularly if you were submitting one extract, is it may be difficult to interpret the reports in terms of looking at 100 providers in one report with a mix of, primary care and specialists in one big report. That just may not be very valuable or meaningful to your providers. But we could definitely, have a conversation offline about the mechanics of that to see if, to kind of tease out if there really has been meaningful enough improvement since the last time that you tried.
Okay.
Yeah. So can I just give you my email, Patty?
Sure.
And then I'll look for something from you. It's just WESSELL@musc.edu.
WESF is in Frank?
Oh, sorry. SS is in Sam.
Sam, ELL.
You got
at
it.
MUSC. Okay, thank you.
Yeah, thank you.
And we'll move to our next caller. Please go ahead.
Hi, it's Wanda Ryan from Flemington, New Jersey.
Hi.
I had a question just about the overlap of these data reports with the information that's being required for meaningful use. I guess I just wasn't sure how this, I guess the software extract, or I guess the extraction of data that you're doing is different than the McKesson upgrade that's required now to do the meaningful use reports. Are they totally separate?
Right. They are right now, Wanda, two separate things. And the way we view this is, we've been providing reports like this for 15 years. And so in a lot of ways, we've got measures that are, clinical quality measures that are far more advanced than the initial requirements for meaningful use. We're developing an approach that will complement McKesson Practice Partners' perspective in terms of meaningful use reporting, and we may be able to provide just additional information in addition to what you'll see in version 9.5 and beyond for meaningful use. So, right, our focus on reporting are on clinical quality measures. We are positioning ourselves to make sure that the types of reports that we give our practices are going to meet the needs for future stages of meaningful use implementation. But for the basic initial reports that are required, those objectives are going to be met within the McKesson system.
But you anticipate that your reports will ultimately be able to be used for meaningful use, or they'll be separate?
For the clinical quality measures within the meaningful use requirements. Right. So, and again, you know, right now in terms of where those start, they're very kind of the introductory level.
Right.
But we anticipate continuing to adapt our processes to meet those requirements for our practices.
But you currently have a program that will extract all this data from the practice partner EHR.
We do. So the extract program exists, and it does require a significant amount of manipulation on our part, you know, in terms of looking at all of the note titles to find people with hypertension, or, you know, evaluating the medication so that we are really, you know, identifying the classes of medications, you know, for specific performance measures. And then the McKesson's system itself will help meet those initial reporting requirements that are different from the clinical quality measures. So, you know, the patients who have an active problem list, for example, those types of things do not exist in the current extract program.
And can you join the network as a specialist, or do you have to be a primary care physician?
You know, we have a couple of specialists that have joined the network over the years. The difficulty is that the measures that we report on often are not meaningful to them. We have had some, for example, OBGYN providers that join and they use the registry or the patient level report to manipulate that data for their purposes. But before a specialist joins, we encourage them to take a close look at our measure set to see if it's of interest to them.
Yeah, we're an endocrine practice. We're an endocrine practice,
right.
So we do a lot of, you know, obviously all the diabetes measures and lipids
Sure.
and blood pressure and
Sure.
all that
And so it could be that there's value there, even in terms of having the patient level report, so that then you can, you know, sort and do other things with it once you receive that.
Okay, thank you.
Yeah, thank you.
And as a final reminder, that is star 1 for any questions at this time, and we'll pause for just a moment to allow everyone a chance to signal. And Ms. Wessel, seeing no further questions in the queue, I'll turn things back over to you for any additional or closing remarks.
Okay, great. I think I'm all set, but do encourage you to follow up with us individually if you have any more questions, and check out our webpage for more information on how to join PPRNet. I appreciate your participation in the web call today, and we'll look forward to your involvement in the network.
That does conclude today's webcast. Thank you all for your participation, and have a wonderful day.